All right, Assalamu alaikum. This is Ijaz, and I've got online class students. So we'll begin with the kidney, and that is chapter 20, Robin's pathology. Yes, you know already. And we are talking about the sick kidneys, right? So we are talking about the sick kidneys, and the sick kidneys lead to death of a person because they are vital organs, very important, and they're two in number. Both are important for us. We need both of them, right? How many nephrons are there in a single kidney? 1.2 million, and so two will have 2.4 million, right? So you know that from your knowledge of histology and anatomy. Nephrotic syndrome pathophysiology. So, yesterday we had done all the normal glomerular structure, and we knew that if anything goes wrong in the diaphragm or in the charges or in the structure, then we are done with it. We will have some pathology somewhere. So, here comes the pathology. Nephrotic syndrome. So we have, please note down, we have three syndromes in the glomerular problems. Those are nephrotic syndrome, nephritic syndrome, and rapidly progressive glomerulonephritis. All three are not diseases by themselves, but they have several diseases that cause these syndromes, right? So once you say your patient is suffering from nephrotic syndrome, you have not reached the diagnosis, just the condition, in which there are several other diseases which involve the same area, Bowman's capsule and the glomerulus. So let me just tell you few important things. There is swelling and there is damage in the fenestra, causing larger fenestra. There is damage in the porocytes, causing pedicles to have larger slits. That means there will be unnecessary leakage, or there is loss of the charges. It means there will be unnecessary leakage of components of the blood that we want in our body. We will unfortunately waste them. So let us define what the nephrotic syndrome is. In the beginning, nephrotic syndrome is caused by derangement in glomerular capillary walls, resulting in increased permeability to protein. Capillary walls are damaged. If the capillary walls are damaged, it means fenestra are larger than before, or there is increased number of fenestra and they must be larger than before. Fenestra size is 7 to 100 nanometers, right? So you remember since yesterday. Increased permeability results from alteration in either structure or physiochemical barriers. So structure is the size of the pores, damage to the endothelium, size of the pores, or physiochemical barrier is the charges that are lost. This allows proteins to escape. We realized yesterday that the smallest molecule traveling around is the protein called albumin. This protein albumin, which is 2 to 4 micrometer, some places say it is 4 micrometer, and some say it is 2. So let us say when it is 4 micrometer in diameter, and if it escapes into the urinary space and then into the urine, it means it is the major basic substance that keeps all the fluid into the circulation and is responsible for osmotic pressure. Osmotic pressure leads to the normal body shape, and if you lose this protein, albumin, and that will result in proteinuria, and that will cause edema. If edema is generalized in the whole body, that is called anasarca, but if it is localized, then it is edema of that particular area. Right, you know that if edema is caused because of the renal causes, that means selective or non-selective proteinuria, then it is pitting. If you press the area for for a while, it results in a depression in that area. We usually do that in the shin or in the foot, and we get a depression and we diagnose it as pitting edema. So another important thing is that in the beginning, if the injury is small, it results in albuminuria. Albuminuria is selective proteinuria. But if the injury is bigger, is larger, then it results in non-selective proteinuria. Several other molecules pass away from the urine or are wasted in the urine. Let us see what is going on. The components of nephrotic syndromes are related to each other. The glomerular capillary wall with its endothelium, glomerular basement membrane, visceral epithelial cells, they act as charge and size barrier through which plasma filtrate passes. They act as size and charge barrier through which plasma filtrate passes. Do you get my point? Components of nephrotic syndrome are related to each other. We just talked about hypoalbuminemia caused by proteinuria, right? Selective proteinuria. Or even if it is non selective proteinuria, there is hypoproteinemia in the body because the proteins have passed out from the kidney. The glomerular capillary wall with its endothelium, glomerular basement membrane, and visceral epithelial cells act as a charge and size barrier. I know you know it. Act as a charge and size barrier through which plasma filtrate passes. Look at this diagram. This wonderful diagram is a normal kidney diagram. And think of larger pores. Fenestra, here are fenestra. Look at, think of larger pore size because of trauma. Trauma can be because of autoimmunity, viral, fungal, or any infection. Can be either it is autoimmune or it is infection. Mostly it is autoimmune. Or right. So it is, even if it is infection, it can lead to autoimmunity, and then there are some drug abuses. They can damage their kidneys through direct trauma. We'll discuss this after we discuss autoimmune diseases. So, do you see a blue ring in this? Yes, this blue ring is the GBM, glomerular basement membrane, and together the endothelium, the glomerular basement membrane, and the porocytes of the visceral epithelial layer, they form the barrier, right? This is the barrier, and now this barrier has to be destroyed. Basically, the pore size increases depending on the amount of injury. If there is a very large pore size and the charges of the GBM are lost, it means non-selective proteinuria. But initially, when the pore size is not too big, it will allow only albumin to go out. So when you say your patient is suffering from nephrotic syndrome, that is it. You said your patient, or I said, or we diagnosed the nephrotic syndrome, then what we mean is massive proteinuria, that is 3.5 grams per day or more of protein loss. And in children there is less in children because the definition will change slightly in children, but however we will use the definition for the adults. 3.5 grams or more protein loss, right? 3.5 grams. So I'm sure you will remember that. Now what will happen to the blood? Decreased albumin will be there in the blood, that is called as hypoalbuminemia. Yes, hypoalbuminemia means less than 3 grams per deciliter in case of nephrotic syndrome. This leads to generalized edema, hyperlipidemia and lipiduria. Can you gather from where do these two things pour in? Hyperlipidemia and lipiduria? Yes, hyperlipidemia has is or hyperlipidemia is the consequence. It is because of the proteinuria. When there is protein loss in the urine, body tends to make up the loss and increases the formation of albumin or the proteins lost. While doing so, it increases the lipid formation as well. This leads to hyperlipidemia, right? So, hyperlipidemia is a consequence of increased protein makeup by the body, or when it tries to repair the body loss, it leads to hyperlipidemia. And this lipid, when lost in the urine, causes lipiduria, right? Nephrotic syndrome, hypoproteinemia, heavy proteinemia depletes serum albumin level at a rate beyond the compensatory synthetic capacity of the liver, resulting in hypoalbuminemia, right? Resulting in hypoalbuminemia. Increased renal catabolism of filtered albumin also contributes to the hypoalbuminemia. Let me tell you a very important fact, a very important, something very important is that if 3.5 grams of protein are lost in the urine, liver has a huge capability of rebuilding the albumin. So why is it that we're still losing uh, lipid only 3.5 grams from the urine, and we're still getting anasarca and edema of the generalized body? Why is it that? Because the liver is compensating for 3.5 grams. So it means that 3.5 gram is only the amount lost in the urine, but the actual amount lost is far greater because the renal tubular cells eat up the proteins as well. They degrade the proteins as well. So the actual loss is more than the body can compensate, right? You can add this up to your book so you will not forget. Look at this wonderful diagram that shows you tears. These tears are the albumin, and the kidney is weeping because it has been damaged. And as it weeps out albumin, it weeps out protein. And let us see how proteins are important for us. The generalized edema is direct consequence of decreased intravascular colloid osmotic pressure. There is sodium and water retention that aggravates edema due to several factors, including compensatory secretion of aldosterone, mediated by hypovolemia, enhanced renin secretion, stimulation of the sympathetic system, and reduced secretion of natriuretic factors such as atrial peptides. So, generalized edema, when we talk about generalized edema, is because of reduced osmotic pressure. And when there is reduced colloid osmotic pressure, do you think what can it cause? It will trigger the body system to maintain the vascular volume and throw certain hormones in the blood that will compensate for the hypovolemia caused by the loss of selective or non-selective proteinuria. So one hormone is aldosterone. compensatory secretion of aldosterone. And then there is sympathetic stimulation that causes vasoconstriction and tries to maintain at least the proper blood flow. And reduction in the secretion of natriuretic factors such as atrial peptides that also causes vasoconstriction. Renin-angiotensin system, how it comes into play, is a blood pressure regulating hormone and a fluid balance hormone. When the renal blood flow is reduced, juxtaglomerular cells in the kidney convert prorenin present in the blood into renin, so it is the kidney again, and secreted directly into the circulation. Do you know where is the juxtaglomerular cell located? It is in the proximal urinary tubule. Yes. So it is in the proximal convoluted tubule that actually touches somewhere the blood vessels, and together they form the juxtaglomerular cells. They sense the blood pressure of the vessel, and then they throw the hormone. They throw it in a non uh, not in an activated, in an inactivated form, in a non-activated form, or you can say in an inactivated form. So that is prorenin, right? So prorenin, plasma renin, then it is converted renin, right? Plasma renin then converts angiotensin released by the liver into angiotensin 1. Angiotensin 1 is subsequently converted into angiotensin 2 by the enzyme angiotensinogen converting enzyme in the lungs. Angiotensin 2 is a potent vasoactive peptide that causes blood vessels to constrict, resulting in increased blood pressure. Angiotensin 2 stimulates secretion of the hormone aldosterone from the adrenal cortex, and aldosterone acts on the kidneys to increase resorption of sodium and water excretion of potassium to maintain electrochemical balance. This increases volume of extracellular fluid, which increases the blood pressure. So since we have a loss of oncotic pressure, or we have got osmotic pressure is decreased because of loss of the albumin, any increase in sodium and potassium and other electrolytes and water retention will lead to the excessive water loss in the body tissues, right? They will not stay in the circulation, they will be lost in the tissues, and this will cause further aggravation of the this will cause further aggravation or worsen the edema. Just look at this. We just talked about prorenin, did we? So how is it stimulated? How is it stimulated? By the liver, by the liver, by the liver. Yes, yes, yes. I know. You know it. Yes, fluid overload. Edema is characterized by soft pitting, and it is more likely to be periorbital region, dependent portions of the body, and if severe, it leads to pulmonary effusion. So we talked about three places in the beginning. When the kidney functions are impaired, we get baggy eyes, or we get bag of fluid under our eyes. We call is bag of fluid under the eyes. This is what happens, right? Bag of fluids under the eyes. It is periorbital edema. Actually, this bag of fluid is periorbital edema. So we are getting periorbital edema, and then it is in the dependent portion of the body, which are basically feet, because we walk from there, and it is the dependent portion of the body. In case it becomes very severe, then the whole body gets swollen to cause anasarca. Lung is one of the place where we get this. So these are the bags of fluid in the eyes. How bad. This is the dependent portion of the body, and this is what pitting edema is. It pits, or it leaves the depression in the foot. And usually edema comes in the foot before it reduces anasarca, right? So this is pitting edema, a depression in the body. Selective proteinuria, and then highly selective proteinuria, we have lost albumin. A protein similar in size to albumin is transferrin, 76 kilodalton molecular weight. And if we lose transferrin, it means that we are going to get kidney induced or the renal damage induced anemia. This is the protein we need for keeping normal iron level in the body. The ratio of low to high molecular weight proteins in the urine in various cases of nephrotic syndrome is manifestation of selective proteinuria. Ratio of low to high molecular weight proteins in the urine in various cases of nephrotic syndrome is a manifestation of selective proteinuria. Yes. Transferrin. So what is transferrin? Iron binding protein. It is a glycoprotein, right? And it transfers. Who's Ali Ijaz? All right. If there is an input, please share it. Is an iron binding protein glycoprotein that transfers iron from duodenum, WBCs, and macrophages to the entire body. So it just catches the iron and distributes it in the body, and it catches the iron from, no matter if it is the GI tract or usually it is the duodenum, and then it is the blood cells, white cells, or it is the macrophages, and it distributes the iron in the rest where it is needed, rest of the body where iron is utilized. The ratio of low to high molecular weight protein in various cases of nephrotic syndrome is a manifestation of selective proteinuria. So poorly selective proteinuria consists of albumin, transferrin, high molecular weight globulins, immunoglobulins, antithrombin 3. They are all globulins. Transferrin is iron transporting protein, and then there are globulins that may be immunoglobulins, IgG, M, A, and so forth, and it could be antithrombin 3. Antithrombin 3. If you lose antithrombin 3, what happens? If you lose antithrombin 3, or if a nephrotic syndrome patient loses antithrombin 3, what happens is lot of thrombosis in the body. So we have in the non-selective proteinuria, we have edema, we have anemia, we have iron deficiency anemia. We have more infections because of loss of immunoglobulins, and we have coagulation in the body. So these defects are because of increased synthesis. Oh yeah, hyperlipidemia and lipiduria. The genesis of hyperlipidemia is because of increased synthesis of lipoproteins in the liver, abnormal transport of circulating lipid particles, and decreased lipid catabolism, right? Increased synthesis of lipoproteins is because they accompanied the protein synthesis. So there was increased lipoprotein as well, lipid production as well, abnormal transport of circulating lipid particles, and then there is decrease in the lipid catabolism because lipid catabolic pathways are also saturated. So all the bad quality proteins increase, right? All the bad quality proteins increase: cholesterol, triglycerides, very low density lipoproteins, low density lipoproteins, and apoprotein. All of those are bad quality proteins that cause, actually we call them bad quality, but actually they are needed at one place or another. It is only if you utilize our things appropriately. But if they are excessive in the blood, they do coagulate, or they do cause narrowing of the blood vessels, eventually ischemia of heart, that is very significant. So there is decreased level of high density lipoproteins. There is decreased in the blood level of high density lipoproteins, but all others have raised level. Lipiduria follows hyperlipidemia because lipoprotein leak across the glomerular capillary wall. Lipids appear in the urine as free fat or as oval fat bodies. Lipiduria follows hyperlipidemia, that is easy to understand. And when they fall off in the urine, they take up certain shape. They are lipoproteins are either reabsorbed in the tubular epithelial cells and then shed along the intertubular cells that have detached from the basement membrane. So the tubular cells, if they try to prevent lipiduria, they eat up the lipid or they take in the lipid, and a lot of lipid in the cells causes damage to the tubular cells. They break away from the basement membrane and fall into the urine. So did you realize what is happening? We initially said that we have lost a lot of protein in the urine, and losing protein in the urine means we have to compensate for what we have lost, try to keep body normal. So once we the body tried to compensate for the lost protein, it started making more lipid, and it caused hyperlipidemia. Hyperlipidemia had all these components raised in the blood. These components caused hyperlipidemia. Hyperlipiduria was it was tried to the lipid component of the urine was tried to be captured by the tubular cells, and in doing so the tubular cells got injured and they were shed into the urinary space. The detached tubular cells got carried away in the urinary space and in the urine. This is what it looks like. If you see the urine of a nephrotic syndrome in on a drop of urine on a slide, this is what you see. These are fat. This is all of this is fat that looks like bubbles. It is insoluble in the liquid medium and it separates as globules in the urine. Oval fat body. Look at the oval fat body. It looks like that because actually the tubular cells are also shed into the urine. They are also thrown out into the urine, and this is what it looks like. Complication of protein loss. Complication of protein loss that includes the immunoglobulins. And if you lose immunoglobulins, you get infections, especially staphylococcal and pneumococcal, due to loss of immunoglobulins in the urine. It means people have to be vaccinated against these bacteria. Complications of protein loss, antithrombin 3 are also common due to loss of endogenous anticoagulants in the urine. For example, renal vein thrombosis. Yes, so if antithrombin 3 is lost, we get thrombosis. And the most common thrombosis is renal vein thrombosis. Such hypercoagulable states occur in patients with membranous nephropathy. Membranous nephropathy is one of the nephrotic syndromes. So there is a list of primary glomerular diseases, and the primary glomerular diseases include one of them include membranous nephropathy. So the feature is very much marked in membranous nephropathy. Thrombotic and thromboembolic complications, renal vein thrombosis. Such hypercoagulable states occur in patients with membranous nephropathy. So we just talked about this. Varies with age and geography. Causes of nephrotic syndrome varies with age and geography. In children, lesion is primary to the kidney. Younger than 17 years, if and If you see a child suffering from nephrotic syndrome, you basically think of a primary kidney disease. Primary kidney diseases are basically autoimmune, or they could be some hereditary pathology of mutation type. Right. So there could be a loss of a protein, a necessary protein that was necessary to build up the normal barrier of the kidney. Or in adults, it could be result of some systemic disease. So most common systemic diseases causing the glomerular damage is diabetes mellitus, hypertension, SLE, systemic lupus erythematosus. There are others as well. There are several others which are not as common, but they can cause nephrotic syndrome. So the primary syndromes are minimal change disease, membranous nephropathy, focal glomerular sclerosis, hereditary nephropathies, membranoproliferative glomerulonephritis, dense deposit disease, and proliferative glomerulonephritis. Minimal change disease, as the name suggests, it is only the charges pathology. Membranous nephropathy, yes, it has got immunological deposits, and focal glomerular sclerosis, immunological deposits. And then there are hereditary nephropathies, membranoproliferative, dense deposit disease. We will read all of them one by one. Diabetes mellitus, amyloidosis, SLE, drugs, non-steroidal, anti-inflammatory, penicillamine, and heroin. Please keep in mind the drugs. People suffering from long-term diseases, for example, arthritis. It could be osteo or rheumatoid or arthritis of any other sort. Could be spondylizing, could be spondylosis, or anything that needs long-term painkillers, right? These painkillers over the time induce kidney damage, and they cause kidney damage in around about 3 years. It takes kidney to die in about 3 years. Infections, malaria, syphilis, hepatitis B, C, and HIV infections, they damage the kidney all by themselves. Malignant diseases, carcinoma and lymphoma. What carcinoma and lymphoma does is they throw a lot of toxic substances that are damaging to the kidney. When the nucleus breaks down, it causes raised uric acid level. Uric acid level damages the kidney. And then there is miscellaneous bee sting, allergy, hereditary nephritis. So they damage the kidney and cause nephrotic syndrome. Nephritic syndrome. So we will just go through what nephritic syndrome is, and then we will see if one can be converted into the other. Glomerular diseases presenting with nephritic syndrome are characterized by inflammation of the glomeruli. This is nephritic syndrome. Red cell cast going out. Oliguria, hematuria, azotemia, hypertension, mild edema. I will go back now. I will go back to the first few diagrams. This diagram. Now we talked about large size of the fenestra in the capillaries, and we said that causes loss of proteins from the kidney. Loss of proteins from the kidney can be selective or non-selective proteins, that is albuminuria and a whole lot of other proteins. Now think like that on the top of nephrotic syndrome, the glomeruli has another inflammatory conditions. The tuft of the capillaries, glomeruli, have undergone inflammation. And if they undergo inflammation, what will happen? narrowing of the spaces, narrowing of the glomerular. So the large fenestra caused by the kidney damage have narrowed because of inflammation. So what will happen? Proteinuria will not be that great, right? So protein will not get lost as much as they were getting lost in nephrotic syndrome. So there will be less proteinuria than nephrotic syndrome, 3.5 grams per deciliter, right? Where is it? No, sorry. Here it is, right? 3.5 grams per day. So why do we say 3.5 grams per day? Because we measure the amount of protein lost in a day, not in a single urine sample, because in a single urine sample there could be less than this amount, and per day there could be a huge urine loss of protein, urinary loss of protein. So we take the whole day loss of protein. We don't calculate simply a single urine protein. So we said that if this gets inflamed, what will happen? The proteinuria will decrease. If proteinuria decreases, so will the edema decrease, because there is more retention of protein in the body, and if the proteinuria gets better, so the edema gets better. So the patient got better? No, 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 no. Actually, the patient is getting worse. The patient will start losing blood cells. Blood cells, when they pass through the renal tubules, proximal and distal, and the Hanley, loop of Hanley, and so forth. So when they pass through the whole of the nephron, they form a cast. They take the shape of those tubules, and that forms a cast. So there is lots of RBC as a whole. There is formation of cast in the sample. We can see cast in the sample, and the RBCs can be distorted because of the urea and other chemicals in the urine, and take form of star and take other forms. Now let us go back to the slide where we were studying. So we were here. See. So we have oliguria, right? Decreased urine, because along with the decreased filtration, glomerular size, since the fenestra have decreased in size, so there is decrease in the filtration. So there is oliguria, there is hematuria, there is azotemia, mild edema, right? So the anasarca's sort of picture has improved to mild edema. Then there is hypertension because of the hormones that are thrown into the body. This is because of the hormones thrown into the body. What is esotemia, and what is, whenever I ask my students what is oliguria, they don't think it is a wise question. But actually, when you get a patient suffering from any renal disease, those are the first things you have to describe in a patient. Suffering a patient, you see a patient suffering from a trauma because of a road traffic accident or some bomb blast or whatever, you catheterize that patient, or we catheterize that patient. And any patient suffering from a brain injury or unconscious patient is catheterized, and we measure the urine output of that patient. That is to find out if there is oliguria, anuria, or polyuria, right? The first setting is to know the renal function. First thing we find out is the renal function. Anuria, failure of the kidneys to produce urine. Oliguria is defined as urine output that is less than 1 ml per kilogram per hour. 1 kg means if it is a 70 kg weight of person, then it will be less than 70 ml per hour, right? 1 ml per kg per hour means it will be according to the weight of the person. In infant, it is less than 0.5 milligram per kilogram per hour. In children, and less than 400 or 500 ml per 24 hours. In general, although this is very specific, 1 ml per kg per hour, in general we say 400, less than 400 ml per hour in 24 hours is oliguria, right? So the rest is the calculation. Polyuria is when there is lot of urine production. Other than that, unfortunately, my sweet students cannot explain what is polyuria. Please write down in your book when the urine output is more than 3 liters per day, that is polyuria. Please write down these definitions in your book because these are really important to know the function of the kidney. So we said there will be oliguria, we said there will be red cells in the urine, and then we said there is esotemia, hypertension, and mild edema. I know that you know hematuria, hypertension, mild edema, but I'm not sure if you know the word esotemia. Right. Are you familiar with all the 7 features? Hematuria, yes, you are familiar. Red cell cast in the urine, we talked of that. Oliguria, you know it. Hypertension, you know it. Mild to moderate proteinuria, you know it. And mild to moderate, yeah, that is what I explained to you. Mild to moderate proteinuria because of reduced size of the fenestra because of inflammation. And edema is there, but it is better. It has become better than in the nephrotic syndrome. And then we talk of esotemia. They are common but less severe in nephrotic syndrome. Nephrotic syndrome does not have hematuria. Even if it has, it is microscopic, and a few red cells may be present there. But actually, there is no marked hematuria. Red cell casts are absent in nephrotic. Esotemia is absent in nephrotic. Oliguria is absent, and hypertension may be there, but not as marked. Proteinuria is well defined. Edema is there, but is marked. So let us see what esotemia is. It is elevated blood urea nitrogen and creatinine level. Biochemical abnormality, right? Esotemia is a biochemical abnormality with raised urea and creatinine levels. Raised blood urea nitrogen, BUN, and creatinine level. It is largely related to glomerular filtration rate. Let me explain this further. What is uremia? If azotemia is raised BUN and creatinine, what is uremia? Uremia is raised BUN and creatinine, and azotemia is raised BUN and creatinine. So what is the difference? The difference is that in uremia, patient becomes symptomatic. In azotemia, there are mere biochemical abnormalities and there is mere biochemical pathology that is not symptomatic. Right. So you know that. Said in azotemia is asymptomatic, whereas uremia is symptomatic. Azotemia is related to many renal disorders, but it could be extrarenal disorders as well. So it could be renal or extrarenal. It means that the primary disorder or pathology of the kidney will cause azotemia, raise creatinine and BUN, or extrarenal disorders could also do the same. Extrarenal disorders are systemic disorders. So we will just see what conditions or just give you an idea. It is a typical features of both kidney. It could be acute or chronic, right? It could be acute or chronic. So azotemia can be because, yes, azotemia, renal origin means that it is because of the primary kidney disease. Pre-renal means that decrease blood flow to the kidney, or hypoperfusion of the kidney. Decrease blood flow to the kidney or hypoperfusion of the kidney are almost the same things. Hypotension, shock, volume depletion, CCEF, congestive cardiac failure, cirrhosis of the liver, that impair renal function in the absence of parenchymal damage. So there is no parenchymal damage. But if there is parenchymal damage, it is renal esotemia, right? If there is parenchymal damage of the kidney, then it is renal. Post-renal esotemia is seen whenever urine outflow is obstructed distal to the kidney. And relief of the distal obstruction is is followed by the correction of esotemia, right? So esotemia versus uremia. When esotemia becomes associated with constellation of clinical signs and symptoms and biochemical abnormalities, it is uremia. Uremia is characterized by failure of renal excretory function and host of metabolic and endocrine alteration resulting from renal damage. Esotemia versus uremia. Uremia patient frequently manifests secondary involvement of the gastrointestinal system. For example, uremic gastroenteritis, peripheral nerves, for example, peripheral neuropathy, and heart, for example, uramic fibrinous pericarditis. Can I? No, I'm sure. Okay, let me narrate some events to you. I had a patient who had renal failure and he was shouting with pain in the abdomen. So we had run an ultrasound on him to see if there was anything wrong in his abdomen because there was absent abdominal sounds. There were no gut sounds in the abdomen. If there are absent gut sounds, what does it mean? It means that there is some kind of paralysis there. The gut is not moving. Why is it not moving? Is it obstruction or is it some other problem? Then we finally came to the diagnosis of uremic gastroenteritis. Right. He had a high amount of BU and creatinine, and that had created gastroenteritis of uremic type. So uremia, you call it uremia when it is symptomatic. Peripheral neuropathy, they're very painful nerves. Uremic fibrous pericarditis, even the pericardium gets inflamed and fibrosed, fibrinous pericarditis, right? So look at this diagram. If you can keep this mind, if you keep it, if you can keep this diagram in mind, you will be able to memorize a whole lot of symptoms. So there is blood pressure, hypertension, raised blood pressure because of inflammation of the glomeruli, and the urine is dark in color because of hematuria, so dark that it is cola colored, black colored, cola colored urine, and there is oliguria, less urine production, and this condition is not specific for one disease but a group of diseases. Mostly in your exam, when you see the word cola colored urine, it refers to post-streptococcal glomerulonephritis, but it could be IgA nephropathy, which is same as Berger's disease. So here is a Berger's disease or Berger's disease, and here is his Coca-Cola, which is Coca-Cola colored urine. This is just to remind you that Berger's disease is a cola colored urine because it is Nephritic Syndrome. All nephritic syndromes are prone to progress further into another syndrome, rapidly progressive glomerulonephritis. Rapidly progressive glomerulonephritis may feature crescent formation. right? Nephritic syndrome is a feature of acute proliferative exudative glomerulonephritis, a component of crescentic glomerulonephritis. It may be in multisystem. It may occur in multisystem disease such as SLE and microscopic polyangiitis. That is the disease you had studied in cardiovascular diseases, the diseases of vessels, polyangiitis. So, nephritic syndrome occurs in microscopic polyangiitis and SLE, systemic lupus erythematosus. Antigen antibody complex from the streptococcal infection, right? It causes headache, raised blood pressure, facial periorbital edema, malaise, low grade fever, weight gain because of edema, and proteinuria, hematuria, and oliguria. Antigen antibody complex in the glomeruli causing inflammation, glomerular filtration rate is decreased. Nephritic and nephrotic. Hypoalbuminemia, massive proteinuria, right? And hyperlipidemia and lipiduria. In nephritic, we have inflammation of the glomeruli, hypertension, oliguria, cola-colored urine, and these are some of the diseases. Acute proliferative post-streptococcal infection, post-streptococcal post-infectious glomerulonephritis. This will be the topic of next lecture, inshallah. And we will meet again. Thank you for being patient listener. Thank you for being with me. And I'll say goodbye after I summarize what we had done today, right? So we studied three conditions in the chapter of kidney: nephrotic, nephritic, and we talked about rapidly progressive. It is nothing but a condition that rapidly progresses towards renal failure. There are three syndromes. First is nephrotic. Nephrotic syndrome has got these five features. These five features together form nephrotic syndrome. Massive proteinuria with 3.5 grams or more of protein loss, hypoalbuminemia, level less than 3 grams per deciliter, anasarca, hyperlipidemia, lipiduria. Anasarca could be just edema as well, generalized edema, it could be periorbital edema, etc. So we had seen that the blood pressure, there is tendency to rise the blood pressure because of loss of the albumin, but the blood pressure may have a slightly, maybe it may be slightly raised, but it is not as much raised as in the nephritic syndrome. Nephritic syndrome features may overlap with nephrotic syndrome features because those conditions are interconvertible. Which one is more severe? Nephritic is more severe than the nephrotic because it progresses from the nephritic, or it can occur independently as well. Without having nephrotic syndrome, a disease may be so severe that it will produce inflammation in the glomeruli and produce nephritic syndrome directly, or it can worsen from the nephrotic as well. So you understand that by now. So this is what a patient looks like in case of pitting edema, in case of all this hypoalbuminemia. And what do we have? Less transferrin, therefore iron deficiency anemia. So we have got less of globulins, immunoglobulins. We saw such patients have more infections. Such patients have decreased antithrombin 3. So such patients have got coagulation, more coagulation everywhere in the body. So most common place where there is coagulation is the renal vessel itself. Then there is hyperlipidemia because of decreased lipid, because of increased formation, decreased catabolism, and finally it gets lost in the urine as well. All bad quality lipids such as cholesterol, triglyceride, LDL, VLDL, lipoproteins, and apoproteins are raised. There is decrease in the HDL. So what urine has is globules of fat like that. So that is what happens. And there is increased vulnerability to infection and thrombosis. In children less than 17 years, it is primary to the kidney. The disease in adults is because of systemic causes. Those are 7 diseases that are of primary significance, or those are primary glomerulonephritis, injuries of the glomerulus alone that will have its consequences on the body. But these diseases, systemic diseases, are the diseases of the body that will influence the kidney in the end, right? So then we talked about nephritic syndrome. Nephritic syndrome is inflammation of the glomeruli, and because of inflammation of the glomeruli, we have 5 other features: oliguria, hematuria, azotemia, hypertension, and edema. We talked about the oliguria, we defined oliguria and anuria, and we talked about differences between azotemia and uremia. So I think that is all for today. Thank you for being with me, and Allah Hafiz till tomorrow.